Kia ora everyone and welcome to this Goodfellow webinar on Best Start Kōwae. This webinar is kindly supported by the National Hauora Coalition and Counties Manukau Health. My name is Dr. Grace Lee. I'm a general practitioner for the Goodfellow Unit, and it's my pleasure tonight to bring to you and welcome some of the members that we have talking upon this particular topic tonight. From the clinical space, we'll be having Dr. Rawiri Jansen, Christine McIntosh and Sue Tutty walking us through the toolkit. And we're also supported by the project managers, Ronnie Whānau and Taria Tane, who are happy to answer any questions along with our clinical experts in the course of the session. So let's get started. We've got a busy and packed session. I'll be handing over to Dr. Jansen to lead the session tonight.
Kia ora tātou. Tātou e huinei mo tēnei kaupapa o tira te hauora o ngā tamariki, ngā pēpi, ngā māma hapu. Welcome. Hey, thanks. First of all, let me thank Goodfellow for setting this up and recording it, because I know there's so much science packed into this tool that people will want to go back and have a look and listen again to the parts of the tool that really make sense. So thanks for joining, everybody who's joining from the far north to the far south and everywhere in between. We're really wrapped. We know that this tool has been installed in 150 general practices up and down the country already, and it's going off, so thank you for joining. I'm Rawiri Jansen, I'm GP at Papakura Marae. I've got the other people in the room who are going to introduce themselves in front of me.
Hi, I'm Sue Tutty. I'm a GP liaison at Counties Manukau Health with an interest in women's health.
Kia ora koutou, I'm Christine McIntosh. I'm a GP liaison also at Counties Manukau Health and also a child health academic and research and study.
Kia ora everyone, Ronnie Whānau, project manager, Gen 2040.
And online we have.
Kia ora koutou, ko Taria tōku ingoa. I am a project manager on the Generation 2040 project.
So we wanted to start kind of by acknowledging that we're standing on the shoulders of others. And so we've listed there for you, it includes the Auckland Regional Health Pathways and the Antenatal First Consult and pregnancy work that's been done, the Perinatal Morbidity Mortality Review Committee recommendations. We're acknowledging the work that the Ministry of Health has done on the guidelines. We've already mentioned, I think, this thing comes to us from John McMenamin and the work that they've done down in Whanganui. We acknowledge the work from He Korowai Manaaki, Professor Bev Lawton and Francisca Story, and the work that they've done on early pregnancy assessment tools. And in front of me, I've got some of the subject matter experts. I've got Christine and I've got Sue, and we've named some of the others that have really given us a tool that's really valuable. We've also had feedback from all of the Northern Region PHO leads and from the Infant Wellness Working Groups, Auckland and Waitemata. This is our agenda. It's got quite a lot of list to it. The first two items are just going to set the scene, and then the last part is really going to go into the science of what sits behind this tool. So thinking about 2040, Gen 2040 is really about projecting ourselves forward to celebrating 200 years since the signing of the treaty. And one way of doing that is to think about a cohort who turns 21. And they're actually all of those who are pregnancies or births right now. And we want to do a good job. If we do a good job of looking after them, we set them on a trajectory that will be really good for them to be able to achieve equity in 2040. So the truth is that if we're going to do that, the health system has to do a good job starting now.
So I became really interested in this work because I'm a GP who's worked both in higher needs communities but also in more affluent communities, and it really was a bit of a light bulb moment for me one day when I saw a young Māori woman who presented to me and about 8 to 10 weeks pregnant, and she presented with her father and her sister, and she was actually really quite excited to find out she was pregnant, which was great. But actually very early in the discussion I discovered that she had some drug addiction issues. And what happened then is I spent a lot of time focusing on that and realised by the time I'd finished with talking to this young woman that I actually hadn't covered off a lot of the basics. And that was my light bulb moment. It's like I was a well-meaning GP, but actually I had been part of the problem here, is that I hadn't covered the basics that I should cover for that young Māori woman in front of me. And that really started me, I was already thinking about this sort of thing quite a lot, but that really started me into the journey to say, actually, how do we reflect back upon ourselves and the job that we do as health professionals, and are we doing everything that we can to achieve equity? So that really got me thinking about, actually, how do we ensure that every person who presents an early pregnancy is getting a thorough assessment that they need, that we're tackling every single issue that will contribute to better outcomes for that mother and that baby through her pregnancy, and for that baby through their life. So that was really a light bulb moment for me. So I think that this is really about saying, actually, what can we do to really make a difference as well? So while we're focusing a lot in this talk on some of the sort of nitty-gritties of preeclampsia and prematurity and so forth, the tool itself is a tool to be installed in general practice. So 150 practices already have it installed. It's something that we have designed as GPs working in DHBs along with National Hāora Coalition on the shoulders of a whole lot of other people. But what this is actually a tool that actually covers everything. So we're not going to spend a lot of time tonight on the wraparound care support for that woman and whānau, but it is in the tools. I just wanted to reassure you about that. But what we've found when we've gone out to speak to practices is they say, can you tell us a bit more about some of these subjects? So some of the things that come up in the tool, particularly because this promotes a nurse-led model of care, they said, can you tell us a bit more? And so that's what we're really trying to do through this webinar tonight. So it's sort of an introduction to the tool, but also a bit more background there. So really important, you can see this lovely mother in front of you with the newborn baby. Yes, it's about everything there, but yes, we're going to focus on some clinical aspects. So the Best Start Pregnancy is actually part of a suite of tools, and so this is really starting from the early pregnancy part, but actually it's about a tool that carries on through in primary care through to that second trimester visit for their pertussis vaccination, following up on anything that's happened that might need some follow-up from the early pregnancy assessment, and taking it through to the 6-week mama and baby check that happens in primary care, back in primary care. And it's really trying to work to improve the flow of information between primary care and midwifery and back to primary care. So it's really trying to improve that care that we have, and recognising that in primary care we actually have a lot of information that we need to pass on to our midwives so that they're able to have a good thorough background for that mother. So here you can see it in the practice management system. It's this is in MedTech 32, and you can see here that it's one of the forms there. And you open it up and complete it within the practice management system. So it's integrated into the practice management system. It is also a web form as well for midwives who want to use it. So that's just sort of orientating to how you'd find it in the practice management system. So some of the things that we wanted to cover off there, so actually it goes through a series of tabs, but some of the things that are built in behind it. So the thing about this tool is we've put a whole, we put it in a format that is easy to follow through in primary care. It has a series of questions under a series of tabs. You'll see some pictures of that coming up. But what's sitting in behind it is a whole lot of decision support. So what we've done is we've combed all of the recommendations, guidelines, and from that obtained all the bits and pieces of information that we need to be able to do a really thorough assessment. And it's some of those things, a lot of those things, I've got to admit as a GP, I would probably not have thought of. So it's that safety net and all that stuff that we probably would not have thought on. So, yeah, so
you make it sound quite complicated, Christine, but actually it's pretty simple what we're asking you to be doing. That when we think of spontaneous preterm birth, which is, you can imagine the perinatal mortality and the morbidity that's associated with preterm birth. And yet the sort of things that are going to make a difference for our mums and babies are the simple things. What we've got down there, it's the urinary tract infections, it's the chlamydia, the sepsis that causes the preterm birth, smoking, very sort of the basic stuff that we should be doing in our practices. So it's asking you here, there's the blood pressure, normal examination.
And you can see here going through the tool. So you can see the tabs across there, and you can see, as Bronnie's showing the little video here, when you put the blood pressure in, it's detected that this is actually a high blood pressure for early pregnancy. It says, hey, this is high blood pressure. So now you need to repeat that measurement, and if it is again confirmed, then you'll want to do some more work on this. And so the little wee document tab that you can see there is actually, will take you, if you click that, will take you to the health pathways. So that's the Auckland Regional Health Pathways above there, hypertension and pregnancy. So it's not got all the information on the pathway, it just says, hey, we've detected a high blood pressure here, go and have a look at the health pathway and figure out the next steps. So all that's built in behind. So that's really important, the preterm birth, because many babies are born preterm because of preeclampsia. So really important to tackle that early in pregnancy.
Now, Christine, you've mentioned how it links into the Auckland Health Pathways. Yeah. What about those practices that are outside of Auckland?
Yeah, no, really good question. Thanks, Grace. So actually, yes, in other areas, it will link to your local health pathways. Yeah. There are some, so depending on the area and how progressed they are with their health pathways, it may or may not be a localised version, but you will find a health pathway at the end of there.
Okay, and just one more question before we carry on. You talked about how it was integrated in the example you gave was with the MedTech system. I'm assuming that this tool will also be able to be used within other practice systems, for example, My Practice and Indices. Is that right?
So it's currently available in Evolution, MedTech 32 and in My Practice, and it's coming in Indices. Yes, we're working our way through all of those.
We've got you covered.
Good question.
Okay. Thank you.
So you can see here the effect of chlamydia on preterm birth. These are things that we should be doing as GPs, is screening for sexually transmitted infections and screening for urinary tract infections. Not only do we need to test, but we need to treat and treat partners as well. Often we forget that, and reinfection is very common in pregnancy, and that's going to lead to, it's not going to get rid of our problem if we don't treat both partners. So we always need to be mindful of that.
So what we're trying to introduce in the tool is to make sure that actually we think every time we see a woman in early pregnancy that we're thinking about these things, and so that we're doing the routine testing that should be offered to every woman. And that we're not forgetting something there. We don't make assumptions about what may or may not apply to her, but we actually do that at every time in early pregnancy, because a lot of preventative care happens around that routine testing. And if we decide to leave something until they link up with a midwife, that may be sometime down the track, and we may have lost that opportunity to treat something early and to get onto things early. So it's really, really important that we're also doing our job in primary care.
And these are just the basics, aren't they?
Yeah.
To treat your urine infections, to look for your asymptomatic bacteria,
yes,
to do the follow-ups for pregnant women. It's not enough to just treat. We have to make sure that infection's gone, and if it's recurrent, to check each month after that.
So that's a really important point that you bring up, because I think a lot of people, I think that I've often spoken to a lot of GP colleagues, and they said, actually, I didn't realise we should do an MSU in early pregnancy, and that actually there should be routine follow-up if she has an asymptomatic bacteria. So really, really important that we hand on that information. If we get that in early pregnancy, that we're handing on to the midwife, hey, by the way, we've got this result to the test, we've treated a UTI, or we've seen the asymptomatic bacteria, and she needs to have a urine test once a month from here on in. Okay, so it's just making sure that we're passing on the baton, we're doing that thorough assessment and passing it on. Another passion for me around is actually what we can do from a preventative way around preeclampsia. So preeclampsia is something that we probably as primary care GPs or healthcare professionals have often left to the midwives and the obstetricians to sort out. But there's increasing evidence, and lots of evidence now, around the use of aspirin to prevent the onset of preeclampsia, but you need to start it really early. You need to start it on or before 12 weeks of pregnancy. So what is built into the tool here is the tool will actually detect major risk factors for preeclampsia. So it will tell you if it recommends aspirin to be considered for this woman. And we know that this is affecting about between 2 and 10% of pregnancies, and particularly for Māori, they actually have an increased risk. So there's a genetic risk, increased risk there too. So it's really important, and we know that if we can start that low dose aspirin early, that we can reduce the risk of preeclampsia for women with major risk factors from 1 in 5 to 1 in 10. So that's a really important change that we can make in primary care.
Okay, so just to sort of recap that before we move on, so in essence, this tool helps provide some form of decision support for certain things like aspirin. Yes. And just a question around, if aspirin isn't appropriate, are there any other therapies that are recommended in preeclampsia?
Yeah, so that's a really good question. I think we have to think about what we can do in general practice and when we should ask for advice. So if we think that aspirin is not appropriate for some reason, we think there's a contraindication to that woman having aspirin, or we're not entirely sure, that's when we should pick up the phone and ask for some advice. I think the thing is not to just defer it though. You know, if it tells you thinking about aspirin, well, you should think about aspirin, and then you should follow it through and ring for some advice. And our obstetricians are more than happy to provide that advice. Just a brief thing around the actual cause of preeclampsia. It's really complex. It's between what's happening in the baby and the placenta and what's happening for the mother and an inflammatory process, but also it feeds into the genetic susceptibility to it. And what they believe aspirin does is it helps to prevent or improve the placental function and improve the development of that placenta and reduce that inflammatory response. So aspirin is really important, and it's a really simple thing that we can do early in pregnancy. And what I get concerned about in counties, and Sue, you probably can answer this too, is a lot of our women find it difficult to be able to find a midwife quite early in pregnancy in counties Manukau, and we completely lose these opportunities to intervene and reduce. And so that's a real equity gap, which I think is driven by our abilities as health professionals and the structure of our health system. It's nothing to do with our women's behaviour. So it's really important that we're able to tackle those issues.
Yes, and I think that if you find a blood pressure that is concerning, don't be frightened to pick up the phone and have a conversation with an obstetrician, because they're always happy to hear about these cases and not wait until they've run into problems. The pathways give really good advice on how to treat hypertension in pregnancy, but if it's really high, just speak to someone.
Yeah, no, so they would be delighted to hear from you. They're really keen to hear about any of these things that we might pick up in early pregnancy. Yeah.
Now, just a quick question with regards to your mention of the guidelines. We've got a question coming through to how you have talked about how certain parts of your particular tool will link into the guidelines. Now, will this be updated on a regular basis? How will that work?
Yeah, so you're exactly right. So this tool is only as current as when it was produced, and like the health pathways and so forth, it needs to be continually updated. So yeah, absolutely. So this is going to need to be reviewed. If we know about anything that's come up immediately, we will make some changes to it. If there's something really new in the guidelines, and I guess I know a bit about that being a clinical editor of health pathways as well, so I'm very linked into that sort of system.
I mean, the pathways are great in the way that you can give instant feedback, and an editor will look at your feedback within a few days, so they're very flexible for being updated.
Yeah. I was also just thinking here that we haven't acknowledged Leslie McLeod, who's done a lot of work around the aspirin and pregnancy and so forth, and she has provided these slides. So I'd just like to acknowledge you here while we're on this one. Thanks. So here it is. It shows you actually the decision support that it gives around this. So it helps to pick up the high blood pressure in the tool. We've just done some screenshots here to show you. It's picking up those small for gestational age babies, and it's picking up the risk factor for this mother because she has diabetes. So that increases her risk of preeclampsia as well. Okay, so it picks this up, and you can see that in the aqua boxes, it gives you some advice around there. Great. So small for gestational age is something that we probably don't really think about a lot in early pregnancy, but it's also another indication for aspirin in early pregnancy. And a lot of work has been done to look at the ethnic differences for small for gestational age. And now usually when you get a discharge for a baby from hospital, you'll often see, or you should see, where that baby was on the centile chart at birth. So what this tool does is it helps you to collect that information around those previous births, see if there's any previous babies that were small for gestational age that would be an indication for aspirin and early pregnancy. And so again, this is another opportunity for early intervention, and that's what this will really support. And it will help us to bring that information through in the Best Start Kōwae tool, the Best Start Pregnancy, so that the LNC has got a good place to start from and carry through that care. Of course, smoking is another cause of premature babies, but also small for gestational age babies. And it's clearly a really important thing to tackle early on in pregnancy. I have great conversations with Michelle, who's at the smoke-free service in Counties Manukau, and she tells me that once a woman engages with them in the smoke-free service at Counties Manukau, it usually takes them about a month to set a quit date. So in my calculations, if a woman turns up perhaps 8 weeks pregnant, well, that might take till 12 weeks pregnant for her to engage with a smoke-free service if we immediately refer them. But if we then refer to a midwife and then the midwife then refers her for smoke-free, then we might be up to about 14 to 16 weeks before she gets the opportunity to engage with smoke-free services. And what we know is that if we can support that woman to be smoke-free by the time that baby is 16 weeks gestation, then we have the best opportunity to improve outcomes for that baby. It doesn't eliminate all risk factors, but at least we know that baby has a better chance of growing and developing at that point. So I think that we have a critical role the moment that we see a woman and we understand that she is smoking, that we support her to get that right support to be able to quit. So that's a really, really important thing. In the tool, it does support the conversation. So we see this very much as a nurse-led GP-supported tool if you're using it in primary care. And in there is it will give you the ABC to smoking cessation. The decision support is also in the health pathway. So it's just leading you down the right direction. It's prompting you to do all the things we know can help with that conversation.
Yeah, one thing I like about the tool is it also talks about smoking in the house and about partner smoking.
Yep.
So it covers all of that.
So it's taking that whole view really about that whole whānau around that woman, and because we know it's quite difficult if the whole whānau are not on board with that smoke-free. So it's a really good opportunity to talk about those environmental things in the family around that woman as well. So here it is with the decision support, decision support around it, and you click on, yep, who else in the family? It's really important to ask those sorts of things because it really impacts your ability to make changes. And it provides some advice, it links to health pathways, and little information boxes give you some information such as, is 1 cigarette a month a smoker or not? Those sorts of things. So it's really helpful from that perspective.
So as health professionals, we're probably very aware of the problem that there is with obesity within our communities, which is obviously a growing problem. We need to have the confidence to have these conversations with our women and our patients, to be aware that it's okay to have the conversation, that not only do women want you to lead these conversations, we've done good research on this, that women want you to institute the conversation, to start it. And if you don't have the conversation, they will actually think that it's not a problem. So if I can leave a message with all our health professionals, please don't be afraid to talk about weight change, about appropriate management for weight. And because it's so important in pregnancy, we have developed these cards and counties that we hope that people will make use of. Now, this is the cover of the card, but inside we have graphs that follow the Institute of Medicine's guideline, And there is a graph to show how much weight a woman of 4 different BMIs should put on through the pregnancy.
Yeah, so there's quite a strong research group in Counties Manukau who've been looking at that with the population in Counties Manukau, the pregnant woman in Counties Manukau. So there's quite a strong evidence base for this, really, in this approach of determining quite early what the healthy weight gain is for that woman in pregnancy, and ensuring that she has that information early. Is that right here?
Yeah, we know that women who are overweight are likely to overestimate the amount of weight that they will put on. And we also know that if you give them a target, so if we can use these graphs and plot their weight change on the graph, then they're very likely to keep to it or keep within some sort of close proximity to that. And giving women a target does make a difference.
So in the tool, we've actually built in the decision support around that. So you can see here that the woman's weight and height has been put in, and it's actually told you that her recommended weight gain is 11 to 16 kgs through her pregnancy. So it's already done that calculation out for you. If you don't know her pre-pregnancy weight and she's presenting in the second trimester, we'll ask you to estimate what her pre-pregnancy weight was. But where it has that link there under healthy weight gain pregnancy poster, you can go from there to the graphs that Sue's talking about, the pamphlets that you can provide that woman, but you can also link to the health pathway there with the document button. So this is just starting really to have that conversation quite early, so that it gives that woman some time to understand what her expected healthy weight gain will be in early pregnancy, before she's well progressed through pregnancy, so that she's put into that position to be able to make some decisions herself about, you know, how she's eating and her exercise and so forth.
Now, these particular pamphlets, are they available in different languages?
Yeah, good question.
No, they're not at this point. They are more graphic, so that having the graph there, I think, will be the most appropriate thing.
Great, thank you.
Yeah, it's partly a tool for plotting up and understanding from the healthcare professional part actually how that woman's tracking in her pregnancy. And I think a lot of the time they are very graphic. There's not many words on them. It's really about the discussion that you have. It's always about how you translate that information, isn't it? So
it's for the woman to track how she's going.
Yep. Yeah, so there really are not many words on the page. We'll put it that way. It's not much to translate. It's how we work as health professionals in translating that. So there's the health pathway there that's just popped up that you can open, and that's where you'll find some additional information. So just always through the tool, if you're not too sure, you're supported with the health pathway that will help you with some additional information. And the nurses who've been using this in practice have said, wow, this is really, really neat, because actually, firstly, I could get in there and I could go through and I could do quite a lot of stuff already in the tool. And we see this as a nurse-led GP-supported tool. And they said, and if I wasn't sure, I knew exactly where to get some more information. So they actually found they could make their way all the way through. It was not a problem. And they learned a lot along the way just from using the tool. So it's meant to be a highly supportive tool. Now, this is a passion for Sue, is actually making sure that we encourage engagement early with the midwife.
There's such good evidence to show that we have much better outcomes if women have that continuity of care and are engaged with their midwife from before 12 weeks, preferably, so that they can build up that sort of relationship that allows them to have the discussions that need to happen during pregnancy. Just as we get them in primary care along getting started with this tool on the best pathway, we need the midwives to continue that care. Yeah,
so I think that's really important. And all we can see those things here are those things that we need to do things about early. So the IUGR is small for gestational age, the diabetes, those risk factors of prematurity. There's a lot of things that we can do really early. And I think the congenital abnormality stuff too. So if we're seeing a woman at 10 weeks in primary care, we need to be thinking and, you know, have we got time to get to a midwife before she needs to have her, her nuchal translucency scans, combined screening, or do we need to start that ourselves while we're setting her up with a midwife? So it is important, I think, isn't it?
Yes,
that.
I mean, we're starting to talk about that 12.5-week scan as your first anatomy scan. with a second anatomy scan at 20 weeks. So you can see that it's growing in its importance, and it allows the woman to, well, for us to pick up any problems early on and being able to look after her care at that point.
Just going to deviate slightly on the one about the scanning. So there is also some decision support around early pregnancy scanning in the tool. What we know is that there are a lot of ultrasounds in early pregnancy that occur that are really not indicated. So, you know, while it might be nice to see a little heartbeat, we really have to think about whether that scan's really necessary. So there's a lot of decision support around whether this woman needs an earlier pregnancy scan than the 12-week scan. Yeah, and making sure that we're using the health dollar wisely, and actually making sure that we've got an equity approach and saying, actually, let's make this the right scans accessible, but let's not overuse or abuse the scanning privileges.
Absolutely, and we get our scanning facilities just so full of people who are having these unnecessary scans that they don't have the time to do the ones that do need to be done.
So it does supply that. So the tool does supply some decision support around when a date's uncertain or when a date's certain enough that you don't need to have an earlier scan than the 12-week scan, which is pretty accurate for dates.
And then we do that 5-week scan and they can't see the fetal heart, and then they need another scan because now mum's all upset because they haven't seen a heartbeat, and you end up with 2 or 3 scans before you've even
none of which will change the outcome. No. So anyway, I just, you know, I've just got down that one. I don't realise we didn't have a slide on it.
Okay. All right. Hey, Grace, it's half time, and I just want to give the halftime shout out to the midwives. And I know there's midwives watching, and you're texting me or whatever. It's a beautiful thing. And we also want to acknowledge the contribution that midwives have made to this tool. And specifically, I want to call out Adi Prede, who's been really, really helpful, great support for this program.
Yeah.
But let's just give it up for the midwives, because, you know, like Sue said, if there's one thing we do well, if we can connect women up with a midwife early, that's just genius. And so the tool helps you do that, and halftime break is over.
Thank you, Rawari. And that's exactly it. It's making sure that we do that handover really well, because what the tool also does is it will pull across any of your long-term medical conditions into the form that can then be printed off at the end of that assessment and provided to the midwife, so that they have a really good basis for starting that care with that woman. So really, really important. So really important to share that information across.
So I want to talk about this slide because I'm quite proud of it, that we have got that decision support about where would you like to have your baby before we've got find your midwife. Because I think that we need to recognise that not all women need to go to tertiary or secondary facilities to have their baby. They don't need that level of care. That childbirth is actually a natural process. And for those that are healthy and well and their pregnancies are going well, then they're better to go to a primary birthing unit, and we know they'll have less interventions through their pregnancy and have beautiful births if we can put them in the right place that's right for them. And in the same way, if women have complications and require secondary or tertiary care, then they need to be in the right place for that. And this needs to be discussed and thought about when you're first seeing your woman who comes in saying she's pregnant. You know, where would you like to have your baby? What are the risk factors that you have? What's the most appropriate place for you? Because we find that women end up finding a midwife, and then that midwife might not birth in a primary birthing unit, or might vice versa. And we've then interfered with that relationship that the woman is developing with her maternity carer. So we want to make the start right and the right place for the right person.
Yeah.
And I think that this slide reflects it really well.
Yeah. So some important things on this slide, really, really important things are, actually, I think that we have a really big role in primary care to ensure that our women are able to connect with a midwife. We know that this can be really challenging in Counties Manukau because we really do have a shortage of midwives, and I think it is our role to connect our woman in with a midwife. So you'll see there add 1 week recall to confirm that she's been able to find a midwife. But I would really encourage our primary care providers to really assist women who we believe might have more difficulty connecting with a midwife and really assist along that process. What you can see there is the buttons there to find a midwife. So really important that you open that and you talk through what sort of midwifery care what her expectations are.
Yeah, so if you have lists of midwives sitting in your practice, please throw them away, because we started producing them in counties and found that the list was out of date before it was even printed. What we would recommend is for you to go to the Find Your Midwife site, and on this version of the tool, it's got the South Auckland, East Auckland, West Auckland. It will go directly into those sites, into the Find the Midwife site for your area. And there's pictures of the midwives. There's when they're available or not available. So you're not ringing midwives who you know are going to be on holiday at the time that your baby is due. It's a much easier way, and you have more choice that way if we use this site. So we would encourage everybody to use that and get rid of your lists of midwives that you might have.
I find this really helpful, because you open this up and the woman often has some ideas about the type of person she might want to be her midwife, and the visual stuff is really important. And then, they are then led down to actually it looks a lot more friendly, because they can see the midwives' pictures there, and the midwives have got a little bit about their style of midwifery care. And I think that's a really helpful thing to have. So if you're somewhere else in the country, it brings up the Find Your Midwife for your area. Okay, so it's smart. It's got the smarts in the tool to know where you are. So really important, and it's really important that we ensure that all the women that we see in primary care are able to link up and engage with a midwife. I think it's a really important role that we have here.
Just a quick question, in terms of us as general practitioners, do you have any words of wisdom with regards to trying to bring in these women who are early in their pregnancy into the practice to be assessed, and also just that acknowledgement point that for a lot of women out there, there's such a shortage of midwives. It's actually really difficult with regards to really gaining access to any midwife, let alone one of your choice. Just wondering if you could put some commentary around that.
Yeah, I think you bring up some really good points there. Around getting women into the practice, I think it's actually by advertising that actually that you're very happy to see women in early pregnancy. They do have the option of seeing their midwife or coming into general practice, but that you are open and available to see women in early pregnancy. The other thing that I have seen often as a GP, you can hear in the corridor or whatever that a woman may have presented and found that she's pregnant and had a test with the nurse, and then the nurse is typically often then booked an appointment with the GP. But I see that as an opportunity that we should be saying, actually, that's the opportunity to get started and get things happening already, get a lot of those bits and pieces done in the tool that can be done by that nurse-led model, get blood pressures done, all those sorts of things, maybe get the blood tests done, and then book the appointment back with the GP. So it's a really good opportunity to really be proactive that way. And it's really hard to measure, but my suspicion is there's a lot of pregnancies confirmed in primary care that don't result in a consultation. And I think that we need to leap into that opportunity. Yeah, really important. Yeah, I can't answer the one about the midwives. I think it's really important that we have a role to make sure that the woman who that we create an equitable access to midwives, and that's about us assisting women where we think they may have more difficulty engaging with the midwife. And that, I think that's about it, rather than letting the people who will pick up the phone and find a midwife quickly, let's actually turn the tables and say, actually, let's really assist this process. Yeah.
I think it depends on what DHB you belong to, and that I'm sure that they have different processes depending on your DHB. But at counties, we have a system where if you do a referral to Women's Health, they will actually ensure that everybody has found a midwife. They go out to the midwives who they know are available and guarantee that everyone finds a midwife, which therefore requires you to do a referral to Women's Health. And often I will do that just as a backstop and say to the woman, if you find a midwife yourself, then you can just say you don't need the one that the DHB has provided, And it's just that extra security, because we know in counties it is just so difficult.
It is the safety net, I think, in counties, isn't it, really? It's just that safety net, because we know it can be really difficult to find a midwife. Great. Yeah. Timely vaccinations, really important. We know that we've struggled to get our booster vaccination rate up. We certainly have around Auckland, and certainly there's an inequity in access that appears in our booster vaccination in pregnancy. But a really nice study done in Rotorua and Taupo showed that actually the most important factor in determining whether a woman came in for her pertussis vaccination was whether or not the practice set a recall. And this is really important, because again, it's not about that woman's behaviour, it's actually about our behaviour and what we did as primary care people. So really important. So this tool helps you reminds you to give the flu vaccination as soon as you can in pregnancy, and allows you to set that pertussis vaccination. So here it is.
It's so easy, isn't it?
Yeah.
It's just easy to do the right thing.
And we've put some information, and you briefly saw that flash up, but that information is there in case you go, oh, is it okay to give influenza vaccine in first thing in pregnancy, or, you know, what's a little bit more information about that? Because that's where I'd see that in nurse-led care, they could leap in and do that influenza vaccine quite early, and that's an opportunity at that first contact. So, yeah, really, really important bits and pieces. And as you can see, this really is a checklist. It's a checklist and a tool, but it's also so much more. Yeah. Okay, other really, really important areas to talk about maternal mental health. And we certainly know from Māori women that they have a higher suicide rate and maternal death in, out of all the ethnic groups in New Zealand. And it's particularly high amongst our young Māori mothers. It's really, really important in pregnancy to be talking about mental health. There are a lot of changes that go on in pregnancy, a lot of also other stresses and concerns that might happen in pregnancy. So it's really important that we ask about it.
I think that we've often thought of suicide in the postnatal group, but actually there's a group, particularly with our Māori women, that are earlier in pregnancy. And that it's something that I think that we need to be aware of right at this first antenatal visit and start talking.
We really
about
need to check in, and so it's, you know, so we bring this in as a routine inquiry, but we also might know about some mental health issues that woman may have had in the past. It's also really important when we talk about mental health that we put it in words that she might use to describe distress, mental distress. And there is no validated tool for mental health screening in early pregnancy, and I was quite surprised to find this when we did that evidence review. But PHQ2 and GAD2 are things that we are used to using. They're really just a trigger, but put things in your own words, or put them in her words to say, do you feel more stressed out than usual? You know, I think a lot of people talk about being stressed out, or not coping very well with various things. And it's about putting it and exploring what her language is around this. She may not recognise as mental health distress. So it's really important that we do recognise that, and that we are actually initiating treatment or referral for that when needed, because there is quite a lot that can be done, and we should engage with those services when we need to. So really, really important that we make this routine.
Yes, I think particularly for our women who have so much social complexity in their lives as well.
Yeah, absolutely. Really, really important. Also really important, obviously, to talk about alcohol use in pregnancy. What we say as clinical people is really, really important to our mothers, and they do listen to us. The evidence is there. So alcohol, obviously, we know is not safe in pregnancy. For all sorts of reasons, as you can see listed there. Women do want to, and they expect to receive advice on alcohol, and it's actually quite effective. But we need to determine how much help that woman might need for alcohol use in pregnancy. And the best practice way of doing this is to use the Audit C alcohol questionnaire, which we've built into the Best Start Pregnancy tool. So we've got a validated way of asking about alcohol use, but it also helps us to establish very quickly whether this is something where the woman might need brief advice and she'll go away and she'll be fine, yep, I can do this, or whether she might immediately need some more support around that, and that's our opportunity for early referral. Of course, fetal development doesn't wait for referrals to come through, and time will tick by and that baby is being affected by that alcohol use. So it's really, really important that we don't just wait for time for the midwife again and then to get that referral. I believe it's really, really important that we initiate this care as early as possible, because every moment is really important for that baby's development. Critically important. So that's the opportunity to identify there might be an issue and then to follow up ongoing once we've identified those issues. So you're really important.
I wonder whether our listeners are worried about all this advice that's popping up on the screen. And I think that if you tick never on or push the button for never, then you're not going to get all this support coming up. So actually the tool is nowhere near as long as it seems as we discussed it.
No. How quickly can you go through it, Roland? You told me the other day. Personal best?
Personal best is 7 minutes.
Yeah.
So I think that's a really important thing to say, is actually if the woman's pregnancy is non-complex, she's a healthy, well woman, this is actually really, really quick to get through. But if there are some more complex issues going on, it takes longer, as it should. And I think that's the important thing. But we're not forgetting anything, and that's really, really important. Yeah.
We've got about 3 more areas to cover, and there's a lot of chat coming in. I can see people are asking, how can I get this tool? And I want to give a shout out to somebody who's in managed isolation who's joined the webinar tonight. So peace, really loving that. We'll carry on. We've got a few more areas to cover.
Okay, so contraception planning, this is
any opportunity to talk about contraception. I mean, you get the woman coming in and saying, well, I didn't quite intend this pregnancy. It's okay, you know, we'll go with it. But maybe that it's an opportunity to say, well, what would you like to do after this baby's born then? I think start the conversation at any time. We know that, you know, good birth intervals are important. Just giving women the choice, having the choice to plan your families, plan your life. So just start the conversation. We're hoping the midwives will carry it on, and by the time the woman's ready to have her baby, we can pop that IUCD in for her when the placenta comes out. That's my aim.
I think that's the thing, is actually having that planned quite early on. You know, so that actually it's not something that's rushed decision when baby's just born. Actually, she's already planned and decided what she thinks might be the best option for her. Of course, being in COVID days, it's really important to think of alternative models of care, and this is already being tested out here. So using the Best Start Pregnancy tool can be used as a telehealth option. And so really, really important that actually it's got that whole checklist there, because sometimes the cues are not quite there when you're doing some telehealth. So you're not, you know, you're a little bit sort of, you know, something that's quite new doing telehealth, and how do we cover off all the things we need? Making sure that we're not deferring that early pregnancy assessment till after lockdown in Auckland here. We can start this early, so making sure we advertise on all of our practice websites, our patient portals, that this option is available, to have a conversation with a nurse, start that care really, really early, make it really accessible. So yeah, think about the model of care and how that might work in your practice. We believe this really encourages early engagement and really thorough assessment. You can get some lab tests and things underway so that she only needs to make one visit to the practice really to get blood pressure done and things like that, and to maybe get the examination and swabs, but that you can do that really efficiently using this tool, but really achieve a high level of care. So really, really important. So here we are, we've got a couple of the staff doing the telehealth consultations here. And yeah, it really does lend itself to that model. Yeah. We have to think alternative models these days. Great. So Sue, did you want to talk about this co-location with midwifery? I think this is something that AD is quite passionate about, and really talking about those opportunities to really think about making connections with your local midwives.
This is the ideal, isn't it? That we're all working as one team, that we have locality-based care, that we can do a soft handover, that when we have the woman who's just found that she's pregnant, we can go and introduce her to the midwife who works preferably with us in the same building, and say, yeah, this is the person you may like to have looking after your care. Again, the woman has the choice always. We can't be too directive, but that soft handover goes a long way, I think.
Yeah, I think it's made a real difference. When I've been working in a practice with a midwife who also works from the same practice, actually the majority of my women would choose that midwife. I think that relationship's really, really important, and then the abilities to have those conversations and those handovers and to be available to each other to sort of say and sort any little issues out. So yes, I think it's really important to be part of a clinical team, a care team.
Absolutely, and doesn't it make the breast immunisation or the mental health referrals so much easier?
Absolutely, absolutely. So I think that this really supports that. It also is really important to say in the Best Start pregnancy tool that actually not all of it needs to be done by the GP or the practice nurse, that actually parts of the tool can be done by the midwife. And if you've got a midwife co-located, you can have a really neat model of care where things get started by perhaps the practice nurse and the GP, and then finished by the midwife, if you can work in that really collaborative way. And I think that that's absolutely ideal. Right, so of course, early pregnancy assessment, you might say, oh my goodness, there's a lot to cover here. But of course, remembering that we get funded for non-LMC first trimester care and primary care. So we already get a funding for that, which I think off the top of my head is around about $115 for a non-complex assessment. But Aurora, do you want to talk about the Gen 2040 payments and the Gen 2040 project, really? Was that Bronnie?
No, Taria's going to come in.
Taria's going to come in.
I'm going to jump in. Thanks, Christine. Yeah, so I guess just to sort of close the loop a bit in terms of how the Gen 2040 project fits in with the Best Start Kōwae. So we're leading the national rollout of the tools across Aotearoa. Like you said, Christine, we're trying to create equitable access to quality care for Māori hapu māma. So as part of the Gen 2040 project, what we will be doing is providing a data capture incentive payment for providers who use the tools with Māori hapu māma or pēpi Māori. So that is, they identify the mother as herself being Māori, or the mother identifies their pēpi as Māori through the tools. And there are specific ethnicity questions built into the tools that ask that question. The payments are split off into 3 different tiers. So the first tier is related to completion of the tools with Māori, and then the second tier is related to referral to core maternity services, and that's done through the tool through a e-referral platform that we will be implementing called Tuku. And then the third tier is a referral to whānau order or community services. So I guess, yeah, that's about it regarding the Gen 2040 payments, other than the fact that we'll be providing the payments on a monthly basis via a buyer-created tax invoice process. So we're going to be distributing the payments to PHOs, and then it'll be the responsibility of the PHOs to distribute the payments out to their provider networks. I guess just to touch on Aware's point earlier, how do you sign up to the tools? You sign up through your PHOs, and Bronnie and I have been sort of actively engaging with PHOs across the country. So if you're not signed on yet, hopefully, fingers crossed, you'll have the platform soon, and you'll be able to use it as soon as possible, really. Yeah.
Just to really ask some questions around making sure that we're all on the same page. So this tool is for everyone, is that right?
Yeah. Yes, so this tool is
yep. But there's additional funding for women that identify as Māori. Is that correct?
Yes, that's
Yes,
correct.
that's
So
correct.
that's the really exciting thing about this tool has those payments around equity. So this is really saying, actually, to really get this flying for hapu māma Māori is to say, actually, we really, really want these things done really, really well for hapu māma Māori, but actually it is available for everybody. So it's something you put into your practice.
Okay.
And
sorry, just with regards to the payments, this is something quite new for a lot of us. So will they be allocated for just as a lump sum, or are they for particular assessments or referrals? And people are just wondering with regards to the payment themselves in terms of how much it's funded for.
So in the total Best Start Early Pregnancy Assessment tool, there are quite a lot of individual data fields. We've selected the data fields that we think will be really interesting to track over 6 months, over 12 months, over 2 years, and they will help us in terms of hopefully giving feedback into primary care, into the PHOs, into the clinics, and saying, this is the areas where you're doing really well, and we're hoping that it's things like immunisation and pertussis, asking the questions about alcohol, and asking the questions about family violence. So you'll be guessing which parts of that whole tool we're going to incentivise the data capture for. But we're trying to be real science-based about it.
Okay.
yeah, so really important to say that yes, this is a web tool, and yes, there is data, health information sitting behind that. Important that when we're looking at that data, that's de-identified data, okay, so it's just some security around that. But this is start of building that health information platform and understanding that actually health information can pass from one tool to the next. So we are working on ways of passing this information directly, with the woman's permission and consent, directly into the maternity clinical information system in Counties Manukau, so that we don't have to do paper referral forms. You just open the next tool and there it is. So we're working really hard about that. But also the other thing about that is that we can actually start to then look at the data that this is creating in a de-identified way, but do some really big quality improvement, equity improvement activity around that. So it is quite innovative and new and exciting. The way that the funding is set up is great because it funds you for the complexity. So you're getting that extra funding around complexity for those important things that we see are really important for hapu māma Māori. And that's a really new way of doing things. So this is a really exciting project from that point of view, I think, and for primary care, because actually we're saying we really value what you do. This is an additional funding, particularly around equity. So yeah. So this page here is actually from showing you the National Hawa Coalition Best Start Kōwae web page, and you'll find the link there. And under the middle section there, information for health providers, there is a comprehensive evidence guide. It tells you exactly where all the information has come from, which guidelines it's come from, why we've put the information in there, and what we believe will be achieved from an equity perspective by putting that information in there. So there is a comprehensive guide in behind there, which would be a really nice addition to having listened to this talk.
Great. Can I ask a few questions?
Sure.
Okay. Now, you had talked about particular topics that were important to engage in with regards to preeclampsia, smoking, mental health. There's just a question from the forum that's been brought forth with regards to provision of decision support tool for other areas of potential complexity in pregnancy, for example, conditions of the thyroid, things related to pregnancy-related asthma type care. Well, is there scope for that? Is that present? Are there things that you're hoping to put in the future in this particular tool?
So that's really important. So there is some decision support around having medical conditions. So what we haven't shown you an exhaustive list of everything today. So what we'd encourage you is to go and have a look at the website and see what else is there. So yes, it does ask about medical conditions. So what this will do, if you open it in your practice management system, it will pull across any long-term conditions that woman has in your practice management system and pull that into it. It then prompts you, if anything comes up positively, to think about those medical conditions. But what we haven't done is done extensive decision support about absolutely everything. And once we start to get to asthma and thyroid conditions, there's so many ifs and buts and what's and so forth around it that actually, no, that's better on a health pathway.
Sure.
That's the thing, we go, actually, yes, she has asthma, and I think I need some more information, go to the health pathway. Okay, and so it has got those links on it, so that you can link in with the right health pathway straight away. So it takes you exactly to the right health pathway, not just to the health pathway suite. So
Great.
the idea is we've built some important things into here that you don't perhaps think about in the background, but that more that clinical stuff and management stuff, it should all happen looking back into the health pathways, for that comprehensive local guidance on what to do.
Okay, now just sort of thinking around this tool on actually either end of the spectrum, just with regards to, I think it probably more relates to that 6-week check area that we didn't dig too deeply in, but someone's wondering how the tool might help with regards to breastfeeding difficulties and linking in with particular individuals or areas of expertise for this. Can anyone sort of talk us around just a few points of the postnatal 6-week check and how that may relate to the breastfeeding scenarios?
Yeah, no, so that's really important. So what we covered here was the early pregnancy one today, and we will be bringing in the 6-week check. Now, what we've discovered in the background is that obviously there is an assessment done by the midwife, and the midwife is the primary caregiver up to that 4 to 6 weeks, and obviously is the source of all that information around breastfeeding support and so forth. But we have an important role also in carrying on any support around that. So that is around the development of those tools and just I think what we need to do around that is, are there any issues, and if there are, here is the health pathway that tells you about the local supports available. So it's really it is a bit of a checklist and say, actually, have you thought about, are there any breastfeeding issues? How can we support this mother to continue breastfeeding? There might be some difficulties. Okay, who is the local support? That's on your health pathway. So we'll have those things, and our intention in the future is to have another of these webinars that covers the 6-week check.
We'll be back.
With some really important things in it, like sooty prevention care and so forth, which is something that I'm really passionate about as well. So
and absolutely contraception and breastfeeding.
Absolutely, contraception, breastfeeding, the wellness of the mother, that handover from the midwife back to primary care. And for that infant, are there any things that need follow-up? Is this baby still jaundiced? Does this baby need follow-up around the jaundice, around their hips, check, around red reflexes, hearing screening, immunisations, etc. It has all of that in it. Okay, so it is comprehensive, it's coming, but we didn't cover it today because this is early pregnancy.
Sure, okay. Just thinking a little bit outside of the box, someone's wondering, for women coming in for a termination, is there any scope for this sort of tool to be utilised in some fashion for it?
I think that's a really big question. Yeah, it's a really good question, because actually saying, well, how much of this tool would you utilise in that situation? And I would say that you would want to use quite a lot of this tool in that situation, but you might not want to immediately use it. So you clearly need to, when you're seeing a woman for the first time in pregnancy, if this is not the news that she was expecting, you need to take her lead as to what she wants to talk about and what her priorities are that day. But I would definitely say that it's really important to cover off a lot around that wraparound support for her. Are there some issues that she needs to be, supported around that need to be worked through as well? So yes, you could use this, and I would encourage you to use a lot of this tool in this situation, but you might have different priorities as you are doing that. And nothing is absolutely essential to fill out in the tool, okay? And that's, we've made no requirement that you fill everything out. So you can use the bits that you think are most relevant at that consultation and then park the tool. And resume that when you need to. But obviously, if you don't do all of the tool and the woman's continuing with pregnancy, you don't get the benefit of the full decision support. And that's just the things to remember. But you do have to be flexible about that, and we have not made it any mandatory fields for that reason. Yeah.
Yes, and I think that we know when a woman gets her first pregnancy confirmed, it's quite an emotional time, and often they will change their mind or need time to think about their decisions. So if you can do as much as possible while it's not inappropriate to have those conversations, I think that it's good to do as much as you can.
Yeah, really, really important, because you can have those conversations around, what the family support is, around smoking, around family violence, around all of the alcohol,
STI screening,
all of that stuff is actually really, really important. And so you might want to stage when you actually talk about that and her journey at that point in time. But I would say that actually that's really important. Yeah, you might have less of a focus on the obstetric stuff to start off with.
Okay. We're about to wrap up, but I'm just wondering if the group here tonight has any key points that they'd like to give to the audience before we do.
I guess I would just like to thank everybody who's been involved in this journey, because we've had this dream for quite a long time, really, starting with John and then Bev and Francesca. I would like to acknowledge Health Promotions Agency, which allowed us to start developing this tool, along with Procon, who have been the developers of John's tool and the Hikora Waimanaki tool, and really the Gen 2040 project, which has just put turbo power behind this project, which is really, really exciting. That would be my final comments.
I would like to talk to primary care really and say you do amazing work out there, and there's this tool that has been provided now that gives us the opportunity to give good quality and consistent care, and I hope that everybody will get behind it and use it and start talking to our women, giving them choices and giving them the best care that we possibly can.
Demonstrate what we can do in primary care.
Yes.
Yeah, that's great.
And for me, I'd like to thank you, Grace, for hosting us and moderating. And also I really want to shout out to these two, the content experts, just the depth of knowledge that you guys have brought to it. You've worked for years to get this thing to a place where it's going to be really useful. Thank you to everybody who's joined. Kia ora.
If you'd like to find any more details with regards to the Gen 2040 project, we'll put a link up on the website page. And also, if you'd like to contact the team further about the pregnancy tool, Bronnie and Taria will link in their emails to the bios, so you can email them and to ask any more questions that you'd like to. Good night, everyone.